Good morning, good afternoon, good evening, wherever you are. Welcome to the European Society of Intensive Care Medicine. We are delighted today to welcome you for a webinar supported by Mindray on data-driven patient safety. This is a very important webinar that is on the DNA of the society, promoting safety, but also the best healthcare for critically ill patients. I am delighted to co-chair this webinar with Professor Maria Cruz Martin Delgado. Everyone knows Maria Cruz, an amazing colleague and past president of the SEMISUC, working in Spain, professor of critical care. And we are going to have a lot of superstars providing us with a lot of thoughts on this big data handling, but also the consequences at the bedside. I'm not going to speak for a long time. I'm passing to Professor Martin Delgado to start to introduce the speakers. Maria Cruz, please.
Thank you very much. Hello, everyone. Very happy to participate in this webinar, Data-Driven Patient Safety Moving Forward, together with Professor Elia Souley, supported by Mindray. And thank you very much for the invitation to the European Society of Intensive Care and this very current and amazing topic. And thank you very much to all of you for your presence. And I have the pleasure to introduce the first speaker, Professor Christian Young. Christian Young is head of the Coronary Heart Disease and Critical Care Division at the University Hospital in Düsseldorf, Germany. And he is going to talk about understanding the reliability and the potential of collected data. Thank you very much, Professor Young, and you can start with your talk.
Thank you very much for the introduction, and thank you very much for inviting me, dear Chairman, and also ESICM for the invitation. The topic has been mentioned. We start together with the introduction. The agenda for this short talk is patient safety. Is it optimal or not? Is the topic relevant? We have to answer the question, understanding the reliability and the potential of the collected data, and which data do we have? And since this is a really, really big topic, I made some selections, and the presentation will not be complete to cover all aspects. So is patient safety optimal? No. 1 in 3 hospitalized patients experience preventable harm. And this means harm is an injury that was caused by the medical management and not the underlying disease, which prolongs hospitalization or produce disability at the time of the treatment or beyond. It can affect quality of life, delay treatment, lead to readmission or death. And examples include wrong diagnosis, wrong treatment, wrong medication, but also other examples, and the list is much longer, like hospital-acquired infections or falls at the healthcare facility. If we look into the data, there are a number of observations. One, for example, summarized in this systematic review. It includes more than 330,000 patients, and the pooled prevalence for preventable harm is 6%, and 12% of this preventable harm was severe or led to death. The highest frequency was among treatments and especially drug treatment. And one special focus, looking at all these publications, is the preventable harm on intensive care units. Just looking on diagnostic errors, a very recent publication summarized that across 29 medical centers and analyzed diagnostic errors. So these are only ICU patients, and 2,500 randomly selected patient records were analyzed, and in 23% of the patients, diagnostic errors could be detected. And if we think this might be a high number, it is even worse if we look at how severe these errors were for the patient. For example, looking at the last line errors that might contributed or resulted in the patient's death is at the prevalence of 23% of these errors. So we have a problem. This also leads to the fact that looking at the US, that medical errors is the third most common cause of death after cancer and heart disease. So this brings it on the top of the list, and also the financial relevance is high, with in the US $20 billion per year spent on errors or preventable harm. So how can we improve? And we need to improve. We need to be interested in all-cause harm, not only specific metrics. We need an optimal tracking, because at the moment, suboptimal tracking of harm without feedback action mostly is present, and we are too late. So we need to report and identify harm and the risk of harm earlier, leading to a chain of action. We need to measure, intervene, and prevent. And the ICU is an optimal place to do that. The intensive care units are a data-rich environment, integrating a lot of information. This can include hemodynamic signals, but also a lot of reports and notes. And if we look at this chain of action, we need data. And this is the topic for today, because what data sources do we have? And I just selected 4. The list is also longer, but I would like to go through this list about own data in hospitals or ICU and collect it manually. I would like to look into local data source, flexible, automated data collections, ICU databases, which are mostly retrospective, and live ICU networks with different organizational principles, for example, following a federated principle. And we will analyze these 4 regarding their reliability and also the potential. We start with the own data assessment, which is very good to start with, because preventable harm can be analyzed and also assessed and then transparently published. And this can be, for example, in this example, be done for hospital-acquired central venous catheter-associated bloodstream infections. And it is there's evidence that reporting this kind of measures decreases this kind of preventable harm. It can be also done across hospital networks, and this is an example from 15 US hospitals that selected a list of harms, action items, and quality aims. And looking over a 10-year period, it led to a more than 75% reduction in preventable errors and their consequences, which is an impressive thing to do. However, looking at the pros and cons, and you will see that for all these dimensions, is that, of course, it has a local validity. It is also potentially easy to apply. It does not need machines or big organizational aspects, but it is prone to errors, and it is focused only on the items collected and not unbiased, and not preventing different aspects or errors or harms. There's also no causal assessment, and it's, of course, much too late. What other data sources do we have? For example, of course, an automated data collection, and this is what is state-of-the-art in a lot of ICUs, which is mainly done by electronic health records. So this is a system that integrates a lot of information, for example, from monitoring devices, but also from radiology, from the laboratory system. It is then organized via a central gateway, collects the data, and stores it in an electronic health record. And it can improve the quality of monitoring, which is really, really much needed, because if you look at the state-of-the-art of quality of monitoring, it has a lot of false alarms, and also the staff does not agree that it is guaranteeing patient safety. In this electronic health records, also harm monitors can be integrated here as an example. It asks the system for information regarding preventable harms, and it is either green or it can be yellow, asking for more information, or it reports the treating team that there's a risk of harm for specific patients. So it also enables the system to apply now and in the future artificial intelligence. It can predict certain circumstances, like be aware sepsis approaching, but it's also reflecting that ICU medicine is about sequential decision making and that errors occur as a consequence of minor errors, like in the Swiss cheese model. So it can also help to guide therapy along specific aspects. So the local validity is there, it is live, which is very good. It can integrate now and in the future clinical decision supporting systems. It can integrate harm prevention tools and, of course, artificial intelligence. However, there are commercial softwares, and it is dependent on, but it can be dependent on local expertise, and it needs for complex models additional external training to increase sample size. So another solution to increase the sample size can be ICU databases. And this very excellent recently published paper illustrates the different data sources, like these are publicly available, and the number increases, like a Japanese database is also recently published. However, looking into the details of these databases, there are also a lot of missing values, and there are artifacts. And we also need to keep in mind that this is collected as unvalidated data. It can also illustrate, and this is our own extraction from the EICU database, that there are sometimes unplausible data, and this is not validated. So like the blood pressure is going down and the noradrenaline doses is going down. We don't know what exactly happens, and we should be careful while training our models using this data. A good thing is that the time resolution of these databases is also becoming better and better, and some of the values are reported, for example, every 2 minutes. However, is this enough? Looking at in this publication, you see that there's a risk of harm for acute kidney injury and myocardial injury if the blood pressure is low. So we cannot allow models to use data to be trained with 5-minute intervals. So this has limitations. However, while looking at the life cycle and the development of clinical decision supporting systems, this data is of crucial relevance and helpful. However, it is a part only of a larger process. These large ICU databases collect large data, and it will help to develop these clinical decision supporting systems and all other aspects of data science and artificial intelligence. However, they are retrospective, and errors and missing values are there. Models are trained without local validity, and are they applicable everywhere? Maybe not. But future solution will be to pre-train models and then do local fine-tuning. So another solution, and we are just getting into it, is live ICU networks. There are different ways to do that. However, these are connected databases, for example, across Europe. And this article has been published today in Intensive Care Medicine, illustrating such a principle that ICUs are connected via a central server. Each ICU has its own data, but AI models and much more are shared in a federated access, which will overcome several of these issues, and then also have large and heterogeneous sample sizes, will be live and integrate data science tools. However, the architecture needs some fine-tuning, but data science technologies will solve that. So if we want to fulfill the aims towards eliminating avoidable harm in healthcare and to follow the action plan developed by WHO and do all the tasks in the framework, we need reliable data. Together with this data, we need the culture, the process, and the technology to use it. And to reduce the risk of harm. So I would like to conclude, the patient safety is a relevant problem on the ICU. Improvement strategies include measure, intervene, and prevent. We need data to do this, and this should be electronically collected. The future will be super institutional live networks that allow AI applications. I thank you very much for your attention.
Thank you very much, Christian. This is a very important presentation, a detailed one, but also a presentation that explains not only the way we should use the data, but also the limits of all these projects. We will keep the questions for the end, and I'm delighted to invite now Professor Massimiliano Greco. Massimiliano is at the Humanitas University in Milan. He is a very important colleague, not only working on cardiovascular issues in the critically ill patient, but also he is a data science supervisor, so the right person to speak now today. Please, Massimiliano, predicting cardiovascular event in the ICU.
Thank you. Thank you very much for inviting me. And so this is the title of my topic. And when I want to start to think about this topic, I like to start with this image of the Delphi Sibyl, which is looking into the future to assess what's going to happen in the future time and to report it to us. So this is the act of a prognostication or the prognostic prediction, trying to find out from our clinical data what is going to happen actually in the next day and in the future. So there are several models that have been used in the last decades, actually from the last decades of the last century. The first models were actually used for prognostication and for not only prognostication, but also for benchmarking and stratification of patients. The first one are very well known, and we found that in every article in the famous table 1 of each article, the SOFA, the Apache, and these were the first. But then we can see that if we go on toward the topic, which is cardiovascular events, we start with an article in 2001 which is not an article, it's a challenge from Physionet. And Physionet is the largest database of physiological data published and the first one from the US. And the first article from Physionet had more than 15,000 citations, I think now. And from there, from this first article of prediction of atrial fibrillation on, this is not critical care, but in a short time, we arrived to the end of the first decades of this century, and we have several articles predicting heart rate variability in ICU, and then we have challenges to predict false arrhythmia and alarms in the ICU in 2015, and then we have also prediction of atrial fibrillation in 2016. This time is ICU, and then in the last 6 or 7 years, we have several models predicting hypotension in the ICU. Some of them have been also commercialized. And all this to say that we have seen this shift from the earlier models, which were dedicated to mortality, and then some of these to clinical deterioration, but mostly were used for benchmarking more than for individual prognostication. We move from that toward more individual prognostication, more personalized prognostication, and using more detailed outcomes, for example, hypotension or atrial fibrillation, or some very specific cardiovascular outcomes. All these can be done, as Professor Young just said, because we have several data in the ICU. For example, we have EKG data, arterial blood pressure, we have end-tidal CO2, we have plethysmography, and so on. So we have very high specific data that we can leverage and to use them in our prediction model. And we have, for example, going back to cardiovascular events, we can have a very high frequency data on the, for example, EKG or on the arterial pressure waveform. For example, this is an arterial pressure waveform. This is the representation. I hope you can see my mouse moving, and then you can see here the translation into a time series. So we have a series of events over time. These are milliseconds. for every 8 milliseconds, we have an appropriate translated values, which is stored. And so we have a very, very tiny regulation and very tiny possibility of collecting data on these events. And so what can we do with all these time series data, high resolution data that we are collecting every day in our ICU? So I want to start with this example from a recent article published by this very well-known group. And what they try to do is to predict the risk of atrial fibrillation occurrence in any patients in real time using some kind of predictions. And here we can see how we can really leverage this data. For example, just to go into more deeply into the model, what did they do? The authors try to use a window of time, which is about 12-hour window. They use 3 different windows. One is just near the atrial fibrillation event. The other is between 6 and 18 hours before the atrial fibrillation, and then there is also another window before that, which is called model 12. They lose a little of discrimination with the area under the curve that is slightly lower in the first models, but at the end they reach a very high performance in prediction of atrial fibrillation. In this, I can already show you that there is a 90-minute gap window before the event, and this is done to prevent the data leakage because we don't want to have informative data from the atrial fibrillation going into our model to avoid over prediction. And the second thing that we are able to do with this model is that these are very complex model. This one is supervised machine learning using gradient boosting applied to decision trees. But in any case, it's quite difficult to understand what's going on beside the machine learning model. And one of our necessity as doctors to prevent these events, like, for example, atrial fibrillation, is to understand what the model is based on. And for this, we have this, for example, Chapelier analysis, which is reporting that we have on the x-axis the effect of each single feature or variable, for example, age, has a very high effect on the risk of atrial fibrillation. And again, maximal heart frequency, the higher the frequency, the higher the risk. And so with all these, what we are able to do is to have an explanation and explainability and the plausibility that some of these that what we are predicting is actually biological and clinical sound reason behind that. And we can follow that. This is also interesting over time. For example, we can see that this is an example of one patient. The patient, we are following three different variables here. And you can see that there is, for example, norepinephrine is using norepinephrine, yes or no. This is a dichotomous. And you can see that there is not so much variation in this case for norepinephrine. CVP was higher at the beginning in blue, then got down, then get higher. And then the value, according the orange one, is not changing so much, but when we go to a maximum heart frequency, you can see that there is a peak in heart frequency, and the peak also in the orange value, which is the Chapelier value. So the highest probability of having atrial fibrillation here, and these are very close together. And it is also reflected in this graph below here, which is actually the total probability risk of developing atrial fibrillation. So we are not only making an explanation in total overall, but we are able to follow the explanation, the explicability of our features, which are variables, over time. And this is very interesting because we are able to see the effects over time. And indeed, what I do conclude in this study that we already know that atrial fibrillation is associated with an increase in complication, length of stay, or mortality, and that there are not so much tools available to predict that in advance. But here, with these new models, this is supervised learning, we are able to do a prediction which is more than 12 hours before atrial fibrillation actually develops. So it's something on which we can actually act. And then they were also able, with recalibration, to increase the external validity of this model toward other data sets, for example, the mimic data set, because this study was done on the UMC data set, but were validated into the mimic data set. And then I want to produce a second example. The first one was supervised learning. This one is deep learning, so unsupervised learning. And in this article, what we are trying to predict is hypotensive events, so severe hypotension. And hypotension is something that, of course, is one of the safety events that we want to predict. And is interesting because we are using a recurrent neural network, and it is a particular model that inside one of the layers, you know that the neural networks are called deep learning because we are not able to go through every layer that the neural network has, but we know that inside that we have a state vector that contains information on time series. So we are able to include the time series into our analysis. And we have also a vector representation for each patient in one of these layers, so we are able to do that. And I don't want to go to the details of this model, but just to show you how it works. We have an input layer here with all the baseline models and some of the physiological signals that we already have seen in the other model, like heart rate or arterial pressure and so on. They have pre-processed and processed here into a specific layer of preprocessing, and then they are concatenated together, and then after several passages and several layers which are hidden, we go out to an output layer which actually is able to produce prediction for mean arterial pressure or heart rate. So here, what actually happens to the at the end, we have a prediction windows using not only baseline data but also all the data from these 30 minutes windows. Here we have a 15-minute gap, and here we have the hypotensive event. In this case, the patient has no hypotension, but we are able to leverage 30 minutes data before the events, and which are ending 15 minutes with a 15-minute gap before the events. So again, we are leveraging physiological signals to have safety of the patient. This is still experimental. You know that some of these models are already being commercialized. This one is an experimental still model, but it's very interesting because it's using a deep learning analysis for that. And I don't want to say that only very high frequency data are useful. I want to show an example in which also data that are not high frequency, for example, non-invasive blood pressure data, can be used for that. And in this case, they reached a very high performance also using this data that are not high frequency, because these are simply non-invasive blood pressure data, and they had the similar diagnostic performance compared to invasive data. I skipped the slide because it's late, but I want to say something that is important for me. We have to avoid in this kind of study the risk of bias. The first one is to be aware of the selection bias. First thing is to define very well our cases, define very well our controls. If we have an error in defining the cases, for example, what is hypotension, what is atrial fibrillation, who is assessing that, we can have a very high problem using this time series data. And this is an example from another study. You can see that the normal analysis should be the black one, but if I have a problem in selection bias, I reach very high performance, but it is biased by our selection. So we have to be very careful on this step. And the other type of bias that I want to mention is the temporal bias. And the temporal bias is very important when we have time series, and it is uniquely associated with studies in which we can choose the period before the event, and we can have unwanted effect that can undermine the validity of prediction. And this is an example from an olive oil study. The olive oil in a retrospective study was associated with protective effect on myocardial infarction. And then when they tried to mimic that in other studies, they didn't get the same results. And the problem was at the end that we are selecting specific time windows that were actually provoking this effect of protective olive oil effect, but it is not real, and it is related with our temporal bias. And then if we take different time windows, we take different times, what we have at the end is that we lose significance of this effect. So please be aware that this is one of the two biases that can influence really a lot your results. Then I want to, before going to the conclusion, mention also heart rate variability. There were a lot of studies, we already seen that at the beginning, on heart rate variabilities. Actually, most of these were not related with cardiovascular events, but with clinical deterioration or directly death, at least in intensive care. Very few were on vasopressor or cardiovascular events. At the end, there are some signs of effect more on deterioration than on cardiovascular events. But the authors of this very interesting systematic review conclude that this cannot be still applied to clinical practice because we have several methodological limitations and too much difference between studies, and so we have to wait for more methodologically sound studies. And the last things we need in the future, we have the opportunity, is opening a window to use very high frequency data to use precision medicine in ICU. You can see in this example here, we have 3 patients. They look very similar, or have the same map and the same target. But if you go to high resolution, instead of having one data input per hours, we have a lot of input of blood pressure for each hour, and you can see that these 3 patients look very differently. This patient crashed here, second patient, the third patient is deteriorating, and so we have the opportunity of using high precision into our ICU to assess a completely new prediction of patient evolution over time. We have these are the sources of high frequency data, mainly the ventilator and the monitor. And all these lead us to a new omics. So you know that there are several omics. There is genomics, metabolomics, proteomics, and there is also radiomics. But maybe in the short time, in a few years, we will arrive to physiolomics, which is the application of very high frequency data to assess patient trajectories into the ICU, using a lot of data, 1 every 8 milliseconds, for example, to assess this trajectory over time. And all this can be applied to new concept for safety, to improve the safety of patients here. And one of the main aspects of this is situational awareness. And I want to go directly to this. What is situational awareness? Situational awareness is where we can use data to crunch them, to get them that are multidimensional to a dimension which is understandable from humans, so from doctors and nurses. We want to flatten them to 1 or 2 dimensions, so to be able to analyze them. And so we can increase our awareness of the whole ICU and the whole hospital, for example, to improve the response to deterioration, for example. And this also applies to clinical deterioration. In our study here, I want to mention the study from our group, in which we were able to assess mean arterial pressure over different wards. Each square is a different ward, and to collect the events of hypotension over the hospital. This is not ICU, this is hospital levels, and to assess all these. And I want to conclude, so how we can use data to predict cardiovascular events. This is becoming more and more accessible. We can handle now time series with both low and high resolution data. And according to our setting, we should use both if possible, or only one of these, but to improve prediction of these events. We should aim to predicting a distant event in time, not event in 5 minutes, but event in 12 hours or 6 hours or something like that, to be really effective. We should be very aware of the selection bias and temporal bias that can actually influence our results, and we can start to improve situational awareness in our hospitals, but then the future is probably going through precision medicine and through physiolomics. And with this, I conclude, and thank you.
Thank you very much, Maximiliano. A nice and very specific talk about predicting cardiovascular events in the ICU. And now we have the opportunity to present our third speaker. She is Liz Piquillot. She is an intensivist and clinician research in an adult intensive care unit in Lausanne, Switzerland, and she speaks about which date reliability predict failure of non-invasive oxygenation and ventilation strategies. Thank you very much, and Liz, you can start when you want.
Thanks a lot for this introduction, and thanks for the opportunity to speak today. Good afternoon, everybody. Then my topic is a bit more clinical, and I'm going to try to show you how we can use evidence from the literature to use data we have readily available in our ICUs to improve our patients' outcome. Then my topic today is non-invasive oxygenation and ventilation strategies. And especially I'm going to speak about acute hypoxemic respiratory failure, not exacerbation of COPD, which is a bit a different topic. Then when we speak of non-invasive strategies used in acute hypoxemic respiratory failure, of course, we speak of high-flow nasal oxygen therapy. And we know that this technique allows reducing intubation rate. Unfortunately, not mortality in the big meta-analysis, but at least intubation rate, which for the patient is already very important. And the second technique that can be used as an alternative to immediate intubation in case of acute hypoxemic respiratory failure is non-invasive ventilation. This ventilatory technique, of course, allows obtaining alveolar recruitment, is efficient to improve oxygenation, and should or can reduce work of breathing. As you know, those two techniques are widely used. But sometimes they don't work. And what means high flow or NIV failure? Of course, this means intubation. But the question here is it a problem to start with a non-invasive technique and to escalate to intubation only if needed? This is clearly the question. And the answer is that it might be a problem. Here you have a graph that shows you the mortality increase you have in case of NIV failure in patients suffering from acute hypoxemic respiratory failure. And you see that the patients who were treated in this series with NIV before being intubated had higher mortality compared to the patients who were intubated early or immediately after entering into the ICU. To note, it was not the case for acute COPD exacerbation. But again, today we speak of acute hypoxemic respiratory failure. And there are other data showing exactly the same. You can see here, again, in patients suffering from acute hypoxemic respiratory failure, mainly patients with pneumonia or acute respiratory distress syndrome. And you can see that the patients who were intubated as a second step after failure of non-invasive ventilation had increased mortality. We also shown some years ago as a secondary analysis of the LUNGSTAFE study. As you know, LUNGSTAFE is a big observational study that looked at the outcome of patients treated for acute hypoxemic respiratory failure and ARDS in a lot of units around the world. And we saw that among the 2,813 patients who were diagnosed with ARDS, about 15% of them were treated with NIV as the first-line treatment strategy. And it was very clear that NIV failure in those patients who were initially treated with NIV was more frequent when the severity of ARDS was more important. Then in case of mild ARDS, we observed 22% of failure. In case of severe ARDS, it was nearly 50% of failure. And those patients who failed NIV had very high hospital mortality, 45.5%, whereas patients who were never intubated had much lower mortality. And probably much more importantly, we showed in this data that ICU mortality was increased in the most severe patients, and it was patients with PF ratio lower than 150 when NIV was used as the first-line treatment. Then this suggests that maybe we should be careful with using NIV as first-line treatment, or at least we must well select the patient for who we consider this strategy. Here are other observational data, and those data, again, in patients with acute ARDS. And you see a big group of patients, 500, and within those patients, about 100 patients were not immediately intubated. And among those patients, 36 were finally intubated, but with a delay. As you can say, the mortality of those patients in the hospital was very high, 50%, and this was clearly not the case in the patients who were intubated immediately after admission. And in those patients, mortality was around 30. Of course, the two groups of patients are not exactly the same, and this cannot be used as a definitive argument against using NIV. But there is some kind of warning here also. And we also have some warning with high flow nasal oxygen. Here, again, an observational study, and you have patients treated this time with high flow, and some of them were intubated early because of early failure, and another group was intubated after more than 48 hours of high flow nasal oxygen, and this was the delayed intubation group. And as you can see, mortality was much higher in those patients who were intubated after more than 2 days of high flow compared to the patients who were intubated earlier. Then again, there is some kind of warning here. Then for sure, it's very important to identify factors that are going to be related to failure, because failure, and especially delayed intubation, seems to be associated with increased mortality. Then, to try to find predictors, it's probably important